So, hello everybody. My name is Dr. Priti, and today we'll be discussing about the important questions related to the SRH module. So, these are the topics which I'm going to discuss. Again, in an EMQ, it is very important to start with the lead statement. Okay. So, here they want you to answer the single most appropriate answer from the above list for each of the following questions. Okay. So, it seems that they want you to answer the causative agent for these presentations. So, a 22-year woman attends the sexual reproductive health clinic with offensive vaginal discharge. She is in a stable relationship. Triple swabs were taken. Wet mount preparation shows the flagellated protozoan. So any patient with the known case of vaginal discharge and the wet mount preparation showing the flagellated protozoan is a trichomoniasis. A 21-year-old woman who suffers from alcohol dependence attends the clinic complaining of persistent watery vaginal discharge. There is no history of irritation and pruritus. She smokes 10 cigarettes on vaginal examination. There is offensive vaginal discharge, fishy smelling vaginal discharge. So vaginal discharge, which is fishy smelling, often associated with the no irritation. Okay, remember, when there is a fishy smell discharge and no irritation, no signs and symptoms of inflammation is there, it is bacterial vaginosis. Whereas if it is a fishy-like smell, which may be seen in trichomoniasis, but it is always associated with some sort of irritation, soreness, signs and symptoms of inflammation. Okay. And the third cause of vaginal discharge is the candidiasis infection, which is a fungal infection, which is a typical creamy white discharge, and it is often associated with the itching and soreness. Okay. Mostly the diagnosis for the vaginal discharges are clinical. Okay. Now, the other question says that there is a patient who is a known case of vaginal discharge. On examination, it's seen to be the bacterial vaginosis. So the confirmation of diagnosis has already been made. She asked about the treatment for sexual partner. Which of the following infections need treatment for the asymptomatic sexual partner? Now, I have told you that there are three reasons of vaginal discharge. One is bacterial vaginosis, which is a clear watery discharge, fishy smell, but there is no irritation, no signs and symptoms of inflammation. The second is watery. It can be watery, it can be green frothy, it can be a plain discharge, which might be fishy smelling, might not, but associated with signs and symptoms of inflammation like soreness, itching, etc. Then there is a third discharge, which is candidiasis, which is a typical smell, typical creamy or you can say curdy vaginal discharge associated with signs and symptoms of inflammation. Now, among three of them, only trichomonas infection is a STI, sexually transmitted. Okay. Neither bacterial vaginosis, neither candidiasis is sexually transmitted. Okay. Now, if they are asking you something which is related to sexual partner, it is always a trichomonas infection. And it is also very important to know that it is trichomonas among all the discharges. Whereas other causes of STIs, it is the only infection where the sexual partner requires treatment even before you test. Okay, you can send the test, but you do not have to report, do not have to wait for the report before starting the treatment. So you have to, partner notification is done for all the partners in last 4 weeks, and you have to start the treatment. You need to send the results, the test, but you do not need to wait for the results before starting the treatment. Okay, so the answer here is trichomonas. Now, with regard to bacterial vaginosis, they are asking you all of the following are true except. So it is excessive anaerobic organisms in vagina. It is an excessive growth of Gardnerella vaginalis. pH is more than 4.5. It is a positive amine test. Overgrowth of lactobacilli. So we all know that it is not overgrowth of lactobacilli. Bacterial vaginosis is basically a colonies which were pathogenic. They overrule the normal commensals which are present, which is lactobacilli in vagina. So more and more of anaerobic, majority Gardnerella vaginalis grows and overgrows the lactobacilli, which is a normal commensal and said to be the healthy bacteria of the vagina, raising the pH. And positive amine test means the vaginal discharge when mixed with the alkali gives a offensive smell, okay, fishy smell. So it is basically an EMCLS criteria, which is used for the diagnosis of bacterial vaginosis. So it's not overgrowth of lactobacilli, it's overgrowth of anaerobic organism, that is Gardnerella vaginalis. So the statement E becomes a wrong statement. Okay. So EMCLS criteria is a thin gray homogeneous discharge clue cells, that is the bacteria, which is cells which are coated with bacteria found on microscopy. Vaginal pH is more than 4.5, and there is a release of fishy odor on adding a alkali. So at least 3 out of these 4, when present, confirms the bacterial vaginosis by EMCS criteria. I told you that third important cause of vaginal discharge is a fungal infection, candidiasis. So this patient is a woman who is complaining of itching, soreness, inflammatory signs and symptoms, curdy white discharge, and she has a recurrent problem. This has been a recurrent problem for her. Now they are asking you what is the treatment for prevention of this infection, which is a recurrent one. Okay. So when there is a vulvovaginal candidiasis, which is a first presentation or acute presentation, we give them fluconazole 150 milligram, 1 dose, okay, or clotrimazole pessary 500 milligram, 1 dose. But when it becomes a recurrent infection, you have to give them the 3 doses of fluconazole 72 hours apart and weekly dose 6 months. Clotrimazole you have to give for 7 to 10 days or 10 to 14 days, and then weekly for 6 months. Okay. Now, because it is a recurrent infection, we have to choose an option which says it is given up weekly for 6 months. So you can say weekly for 6 months is there for clotrimazole also. For fluconazole also, it's there for 6 months. 6 weeks is wrong. Nystatin is only used when there is a resistance, and miconazole is also not preferred. So which is a better option for this lady? Because fluconazole is oral is always preferred. Then it is fluconazole, which is given. First 3 doses are given about 72 hours apart, and then you have to give them weekly for 6 months. Okay. So for recurrent vulvovaginal candidiasis, it is fluconazole given 3 doses 72 hours apart and weekly for 6 months. So as I have told you, for acute infection, 1 doses are enough. For recurrent infection, you have to give 3 doses of fluconazole followed by weekly, and clotrimazole 7 to 14 days, then weekly for 6 months. Recurrent vulvovaginal candidiasis, which is resistant to the azole groups, you can give nystatin pessaries. So it's a very important question to know about the vulvovaginal candidiasis infection, how to manage when the patient is pregnant. Okay. Now in pregnancy, you all have to remember that oral fluconazole is contraindicated. So it's the same question. The patient has recurrent vulvovaginal candidiasis, but this time she is pregnant, 13 weeks pregnant. So as I told you, fluconazole is contraindicated. So fluconazole options are out. 3 options, A, B, and D are out. Even E is out. Only we are left with the C option. Okay. As I've already told you, first thing for recurrent infection is to give them a regular dose of 7 to 14 days. Okay. Then you have to give clotrimazole pessary weekly for 6 months. Okay. So remember, for vulvovaginal candidiasis in pregnancy, the drug of choice is clotrimazole pessary given for 10 to 14 days and then weekly for 6 months. So again, for acute infection, only clotrimazole for 7 nights. Recurrent infection, clotrimazole for 10 to 14 days and then weekly for 6 months. Fluconazole is not given. Now, the causes of vulval ulcers are painful and painless ulcers. One of the very important causes of vulval ulcers is when the patient suffers from syphilis. It's a painless ulcer. Okay. Painful ulcers are 2, herpes and chancroid. Painful ulcers are 2, herpes and chancroid, and painless ulcers are syphilis, LGV, or donovenosis. So in syphilis infection, they are asking you that the patient is 18-year-old, primi gravida, 20 weeks pregnant. Heavy vaginal discharge with mucopurulent rashes are there, which is given in the picture. Ultrasound of the fetus shows fetal ascites. So it is a typical presentation of the secondary syphilis where even now the baby is infected and having the symptom. So what is the most appropriate management option? For the patients who suffer from secondary syphilis in pregnancy, the treatment of choice is benzathine penicillin single dose. Okay. So ceftriaxone, amoxicillin, azithro, and acyclovir definitely is not given. So benzathine penicillin single dose is an option because this patient is in the 20 weeks. So any patient with the secondary or primary or latent syphilis less than 2 years, which is considered an early syphilis in first and second trimester, benzathine penicillin as a single dose is given. If she presents beyond second trimester, that is in third trimester, 2 doses weekly apart will be given. But for the late disease of unknown latent disease of unknown duration, you give benzathine penicillin 3 doses weekly apart, whatever gestational age she is coming to you. Now, another reason for the ulcer is, I told you, donovenosis. So there is a lady who is from Australia and migrated to US. She attends the STD clinic with the painless ulcers on her vulva. 35 weeks pregnant, smears of genital ulcers are taken, and they are shown on the slide like this after the GIMSA staining. So GIMSA staining on the ulcer, it shows this pattern. This is known as donovenous bodies. Okay, and this is diagnostic of donovenosis. Now, ideally, the treatment of donovenosis with regard to pregnancy is different. Okay, so the causative agent is Klebsiella granulomatosis in this case, and the treatment of choice, because she is pregnant, is 1 gram azithromycin given weekly for 3 weeks. Okay, so for donovenosis infection in pregnancy, the treatment of choice is azithromycin 1 gram once a week for at least 3 weeks. Okay, sometimes they also ask the Klebsiella, what is a causative agent? Okay, remember it is Klebsiella granulomatosis. Now, one of the very important questions which are related to the ulcer, specifically the syphilitic ulcer, is how do you diagnose them? So a very important question is that for diagnosis of syphilis, what test do we do for a confirmatory test? Okay, routinely, if I say, we can say that normally we come across the test called VDRL, but if we suspect that it can be syphilis, the tests which are done are enzyme immunoassay or chemiluminescence immunoassay. So if those tests are positive, the test which is done for a confirmation is a TPPA test. Okay. So they are asking you that there is a genital ulcer, which is considered to be sexually transmitted disease. Few weeks ago, she visited Southeast Asia, has some relationships. Examination reveals a painless ulcer. The diagnosis of syphilis is made, and they are asking you the test to confirm the syphilis. Okay, so the test which is done is a TPPA or TPHA test, but the test which is done for the diagnosis is basically enzyme immunoassay or chemiluminescence immunoassay. So if EIA or CLIA are positive, the confirmatory test which is done is TPPA or TPHA. Now, again an EMQ where you have to first read the lead statement, the most likely organism responsible for the condition of these patients. So 24-year-old woman comes to genitourinary medicine clinic complaining of multiple ulcers which are painful. Ulcer has erythematous halo and inguinal lymph nodes are painful. So I told you painful ulcers are two. One is herpes, second is chancroid. So because the herpes is more common than chancroid, and moreover the herpes ulcer is a clear base erythematous ulcer. Okay. So this is basically a case of herpes. Now, second question says the 21-year-old lady attends the emergency department with a genital ulcer, very anxious that it could be an STI. She has been to a Southeast Asia and has sexual intercourse. Examination reveals single painless ulcer. So painless ulcers are 3, that is syphilis, LGV and donovenosis. So single painless ulcer always is syphilis, and it is caused by the organism called Treponema pallidum. Because they are asking the organism, so here also the answer will be herpes simplex virus for the question number 3 and Treponema pallidum for the question number 4. Then there is a 24-year-old lady who comes to genitourinary medicine clinic complaining of multiple painful ulcers. On examination, they are sharply demarcated with the yellow exudate and the base, also painful inguinal lymph nodes. Okay, so again there are painful ulcers, so either it will be a herpes or chancroid. As I told you, the hepatic ulcers are clean base ulcers with the erythematous base, whereas the dirty base or yellow exudate is basically a chancroid, and the chancroid causative organism they have asked you, so the answer will be Haemophilus ducreyi. Okay, so you can get as a diagnosis, you can get as an organism. So you have to be very clear that what organism is responsible for what type of infection. Now, there is a lady who is a para-2, HIV positive, CD4 count is 73. She's on antiretroviral drugs. Routine smear was done and she has an ulcer on her labia, which is suspected or clinically diagnosed as herpes simplex virus causing ulcer. So what will be the treatment for this patient? So we all know herpes simplex virus is treated with acyclovir. The treatment drug of choice is acyclovir 400 milligrams 3 times daily for 5 days. But when the patient is HIV positive, the dose of the drug still remains the same, but the duration, the frequency in a day, and the total time increases. Okay. So remember, for HIV positive herpes simplex infection, you give acyclovir 400 milligram, but it is not given thrice a day 5 days, but it is given for 5 times 7 to 10 days. Please remember, this is a very important question. So as I told you, a general recommendation is 400 milligram for 3 times a day for 5 days. Whereas for HIV positive, it is 400 milligram 5 times a day for 7 to 10 days. Okay, moving on to another set of questions, which is EMQ related to some contraceptive questions. So there is a lady who is having a contraceptive patch from the last 12 months presents to you because the patch was found to be detached from its base for approximately 36 hours. And during that time also, she had an unprotected intercourse. So they want your advice. So contraceptive combined transdermal patches, which contains estrogen and progesterone both, and it is a type of combined hormonal contraception. If the general idea is that the patch is put weekly. For 1 week, they will put, for the next week, they'll put a new patch. For the next week, they'll put a new patch. For 3 weeks, they'll put a new patch. And the 4th week is a hormone-free interval. So no patch is used. And during that time, they will have their menses. Now, for any patch which is detached for less than 48 hours, okay, it is same like missing of one pill, one oral contraceptive pill. So one pill missed, or there is a patch detachment for less than 48 hours. Whatever week it happens, week 1, week 2, week 3, during the course of the treatment, there is absolutely no issue. Okay, you can tell her, okay, no issue. You can just put a new patch right now. You do not require any additional cover, and you do not require emergency contraceptive, even if you have UPSI in that period. Okay, so for this patient, the best answer is the E answer, use a new patch, and there is no need for additional or emergency contraception. So anything which is missed for 1 day, or a patch or ring problem which has happened for less than 48 hours, whatever week it happens, week 1, week 2, week 3, we all know that combined hormonal contraception is taken for 3 weeks and the 4th week is a gap. So if happens anytime, there is no issue. Take the most recent missed pill for the patch, put a new patch, no EC, that is no emergency contraception, and no AC means no additional contraception is required. Okay. Moving on to the next question, which says that there is a patient who has, the lead statement, you have to see that there is a missing of the contraceptive pills, and they're concerned about the unplanned pregnancy, and they're asking you appropriate advice for that question. Okay. So 23-year-old lady who is on low dose ethinyl estradiol combined oral pill from the last 3 years, unfortunately forgot 2 pills in the 3rd week. Okay. Now, what happens when there is a missing of 2 to 7 pills? Okay, if it happens in week 1, week 2, week 3, basically they divide it now. For week 3, when they happen, they say if you have used the first 7 pills regularly, then you are definitely protected from pregnancy. So even if after the missing of 2 pills in 3rd week, there has been UPSI, they do not require EC. Okay, but yes, they will require, and they have to take the most recent missed pill, rest of the pill at usual time, additional cover for 7 days, and they also will require to omit the hormone-free interval. Means that 1 week gap which is given is not given now. Okay, so they will start the new packet once they finish this packet. Okay, so the best answer over here is J, which says take the most recent missed pill, rest of the pill at usual time, finish the pack, skip the hormone-free interval, start a new pack, and use the additional cover for 7 days. Now, there has been no mention of unprotected sexual intercourse in this question, so we do not want to mention anything about the emergency cover over here. So, as I told you, if there has been missing of 2 to 7 pills, or any patch detachment or ring has been removed from vagina for 48 hours or more, if this happens in week 1, take the most recent missed pill, rest of the pill at usual time. Put the same ring, but always use a new patch. Additional cover for 7 days, and if there has been UPSI, emergency cover is also given. But if it happens in week 2, the same thing has happened, but no EC is given. Week 3, same thing, but no EC, and you have to omit the hormone-free interval. Next question says 20-year-old Katie. She's again on the ethinyl estradiol containing combined pill, misses 2 pills. And she has 9 pills left in the packet. 9 pills left in the packet means she has missed 2 pills in the week 2. So as I've already told you, if it happens in week 2, take the most recent missed pill, rest of the pill at usual time, emergency cover not required, and additional cover for 7 days is given. Okay. So the answer for this question is this. Okay. Now, one of the very interesting question is that there is always a drug interaction with the combined pills. So we all know enzyme-inducing drugs like some drugs like carbamazepine, phenytoin, they reduces the efficacy of combined pills. So we don't give combined pills and these pills together. Okay. But there is one anti-epileptic drug which efficacy is reduced by combined pills, the other way around. Okay. And they are asking you that which anti-epileptic drugs efficacy is reduced by combined oral pills. So it is lamotrigine. Okay, lamotrigine dose is decreases with CSCs, increasing the seizure frequency. So you never combine lamotrigine with CSC. So if any patient is taking lamotrigine, you have to not give her CHC as a contraceptive option. A 32-year woman consults you for the risk of VTE, venous thrombosis. She is on combined pill, which has 35 microgram of ethinyl estradiol and norethistron as a progesterone in it. How will you counsel her? She should change to intrauterine device. She can, if she's at high risk, she can change it. She should change to another oral contraceptive which contains one of the new progesterones. So remember that newer progesterones as compared to the older one has higher risk of venous thromboembolism. Her current pill has the lowest risk of blood clotting. Her current pill has highest risk. Use it only for 1 year. So the thing is that her current pill has the lowest risk. Okay. So what advice if the patient is already taking something and she just wanted to know the risk of VTE? The best advice to her is you can continue because as compared to other progesterones, if you are planning, norethistron containing drugs have lowest risk of causing the venous thromboembolism. Okay, again an EMQ. So let's check the lead statement. Woman is seeking contraception given in a particular set of medical circumstances. In each scenario, select the most appropriate contraceptive method. From the options listed, the same contraceptive method may be valid in more than one clinical scenario. So 26 years old lady who's having infrequent periods, mild hirsutism, mild acne, and polycystic ovaries, wishes effective contraception that may also reduce the risk of hirsutism and acne. So the thing is that we all know that combined hormonal contraceptions are the best for irregular periods. They also reduces the acne probability and the unwanted hairs. So the best drug for this patient is the combined oral contraceptive pills. Okay. 28-year-old woman has a spontaneous delivery of the child 12 days ago. Body mass index is 28. She is breastfeeding, would like to have effective contraception. Implant facility is not available. So select the most suitable option for her. Because she is 12 days postpartum breastfeeding, definitely CHC can't be given because it can only be given after 6 weeks in breastfeeding mothers. Intrauterine devices can't be given until 28 days postpartum. Implant facility is not there. So the only option she is left actually is POP pills because somewhere as compared to POP, DMPA also theoretically increases the risk of venous thromboembolism. So POP immediately postpartum is in safest category of UKMAC1, whereas DMPA is UKMAC2. UKMAC2 does not mean it is contraindicated, but it is better avoided. So you will give her something which is more safer as compared to DMPA. So the answer here is progesterone only pills. Thank you guys. I hope this lecture helps you all in preparation. So good luck and thank you everybody. Thank you so much.